Imagine a microscopic, unseen marvel operating inside your body right now with every single breath you take. It's this fundamental exchange, silent and astonishingly efficient, that literally keeps you alive. We're talking about gas exchange in your lungs, kind of a masterful piece of biological engineering that, well, often goes unnoticed. Today, we're going to pull back the curtain on this vital process, transforming what might seem like dense, complex concepts into clear, maybe even surprising insights about how your body breathes. Welcome to the Deep Dive. This is where we take a stack of your sources, articles, research, our own notes, and really extract the most important nuggets of knowledge. Think of it as your shortcut to being truly well-informed. Today we're doing a deep dive into the foundational medical physiology of gas exchange in the lungs. We're pulling insights directly from the updated edition of Walter F. Boron and Emile L. Boulpaep's Medical Physiology. So, our mission today is to break down the intricate details of how oxygen actually makes its way into your blood and how carbon dioxide efficiently exits. We'll move from the big picture down to the microscopic specifics. We'll connect it all to real-world clinical scenarios and hopefully help you feel confident mastering this essential material. So get ready to breathe easy as we explore the invisible forces at play. Okay, let's unpack this. We breathe in oxygen, we breathe out carbon dioxide. Simple enough, right? But how does this critical exchange actually happen inside our lungs? At its core, what's gas exchange really trying to achieve, and does it require a lot of energy?
Well, it's beautifully simple in its goal, really. It's all about ensuring a steady flow of oxygen from the tiny air sacs in your lungs, what we call the alveolar, right into your bloodstream, specifically into your pulmonary capillaries. And, at the exact same moment, moving carbon dioxide in the opposite direction from your blood back into those alveoli so you can exhale it. What's truly astonishing, I think, is that this entire critical process, the actual movement of gases across that lung barrier, happens by simple diffusion.
Simple diffusion, that sounds
Okay.
too easy for something so vital. I kind of imagine some active pumping mechanism.
Yeah, that's a common thought. And actually, early physiologists did theorize that the lung actively secreted oxygen into the blood. But we now know that both oxygen and carbon dioxide move purely based on, well, random molecular motion. The diffusion itself doesn't directly cost the body energy, which is quite a remarkable feat of evolutionary design. However, and this is key, the body does have to do work. It works in the form of ventilation, breathing, and circulation, which is your blood flow, to create and maintain the necessary concentration differences. Without those differences, those gradients, the gases just wouldn't have a reason to move, right? It's all about cleverly setting up the conditions for this passive movement.
Okay, so if it's simple diffusion, then there must be some rules governing it, because nothing in physiology is that simple in practice, is it? This is where it gets really interesting, I think. Fick's law of diffusion. What does this master key tell us?
Indeed. Fick's law is absolutely the guiding principle here. It tells us that the net flow of a gas across any barrier, like the one in your lungs, is directly proportional to two main things. First, the diffusing capacity, which we label as DL, you'll hear that a lot. And second, the concentration gradient of that specific gas across the barrier.
Concentration gradient.
Yeah.
Yeah, that sounds a bit abstract. Can you maybe give us an example that makes it more tangible? Like, what does that really mean in practice?
Absolutely. Let's imagine two rooms separated by a thin wall with oxygen on both sides but at different pressures, say P1 and P2. Fick's law reveals something really crucial. The net movement of oxygen from the high-pressure side, P1, to the low-pressure side, P2, is proportional to the difference between P1 and P2, not the ratio. So if one side has 100 units of oxygen pressure and the other has 95, that 5-unit difference is what drives the flow. But if one side has, say, 2 units and the other has 1, the difference is only 1 unit, even though the ratio is much higher, right? 2 to 1 versus roughly 1 to 1. That so what here is that it's the sheer push, that absolute difference in partial pressure that drives the flow. That difference is the driving force.
Ah, I see. That's a crucial distinction then. It's the absolute push that matters, not just how much more concentrated one side is. Okay. Now, what goes into that diffusing capacity, or DL? What makes a barrier good at letting gases through? Is it just thickness?
Good question. DL is a really critical factor, and it's determined by properties of both the gas itself and the barrier it's crossing. You can think of it as the lung's overall gas exchange efficiency score, maybe? So first, let's talk about the gas properties. There's molecular weight. Simply put, lighter gases move faster. Like helium in a balloon rises quickly because it's light. The heavier the gas molecule, the slower it diffuses. Graham's law covers this, technically. And then solubility in water. This is absolutely vital. Gases have to dissolve in the watery layer lining your lungs barrier before they can diffuse into the blood. Henry's law relates partial pressure and solubility. So poorly soluble gases, like nitrogen, for example, just don't diffuse well across that barrier because they don't dissolve easily in that liquid layer. Second, you've got the barrier properties. You mentioned thickness, but first let's consider area A. This one's pretty intuitive, I think. More surface area means more opportunities for gas molecules to cross. And your lungs, well, they boast an incredible 50 to 100 square meters of surface area that's roughly the size of a tennis court, all folded up inside you. This massive area is designed to maximize gas exchange. Then there's thickness, like you asked. The thicker the barrier, the slower the flow. I like the analogy of a skier going down a mountain. A steep, thin slope, that's a fast trip. But a shallow, thick slope, even if the total vertical drop is the same, makes for a much slower journey, right? Your lungs barrier is incredibly thin, about zero point 0.6 micrometers on average, to ensure really rapid diffusion. And finally, there's a proportionality constant, quote, which sort of fine-tunes how a specific gas interacts with that specific barrier material.
Okay, so Fick's law. It's kind of like Ohm's law for electricity. I've heard that analogy before, and it always helps me visualize these things. Is that a fair comparison?
It really is an excellent analogy. In Ohm's law, electrical current is the voltage difference divided by resistance. In our case, the net flow of gas is like the electrical current. The diffusing capacity, dl, is like the reciprocal of resistance or conductance, if you prefer. And the partial pressure difference acts just like the voltage difference. It really helps us see how these factors interact to determine the overall rate of gas exchange. It puts it in familiar terms.
Right, that clarifies the physics behind it. But that's the simplified model. The human lung is far from simple, isn't it? It's this complex living tissue. What happens when we apply Fick's law to the actual, incredibly intricate reality of our respiratory system?
You're absolutely right. The lung isn't just one simple barrier. It's actually a sophisticated three-ply structure. You've got an alveolar epithelial cell layer, then a capillary endothelial cell layer, and in between, an intervening interstitial space. It's truly remarkable how this delicate, multi-layered membrane, despite its incredible thinness, is surprisingly strong. That's thanks mainly to type IV collagen providing structural support.
Wow, okay, so oxygen has to cross all those layers just to get to a red blood cell. I'm picturing like a tiny obstacle course, a microscopic journey for each oxygen molecule.
It really is a journey. You can actually think of oxygen having to cross maybe 12 discrete mini hurdles or mini barriers just to reach the hemoglobin inside a red blood cell. Each of these mini hurdles has its own tiny resistance to diffusion. If we stick with our electrical analogy, you can think of them as many tiny resistors connected in series. Each one adds a bit to the total resistance to flow. So the total membrane diffusing capacity, which we call DM, is determined by how easily the gas navigates all these individual layers combined.
Okay, that makes sense. And then once it crosses those physical layers, the oxygen has to actually bind to hemoglobin inside the red blood cell, right?
Yeah.
That final step. How does that crucial binding process factor into this overall diffusing capacity, DL?
Yes, that's the key final step. That binding happens at a finite rate, it's not instantaneous, and it absolutely contributes to the overall diffusing capacity, DL. We represent this binding rate by a term theta times the z-c that basically considers how quickly the gas latches onto the hemoglobin and the volume of capillary blood available for it to latch onto. So our lungs' overall gas exchange efficiency score, DL, isn't just about how easily gas crosses the physical lung tissue, that's the DM part, but also how readily it binds to hemoglobin in the blood once it gets there. Both play a crucial role. You can think of it like two gears in a machine. If one slows down, the whole process is affected. The overall DL depends on both the membrane crossing and the reaction with blood.
Okay, so this binding step, is it equally important for all gases? Like, is it as big a deal for oxygen as it is for something like, say, carbon monoxide?
Not at all. And this is a really key differentiator in how different gases behave in the lungs. For oxygen, that hemoglobin binding term, the 1 over theta times Vc part of the resistance, is actually relatively small. Oxygen usually zips across the membrane and binds pretty quickly. Why? Because your hemoglobin is already about 75% saturated with oxygen when it arrives at the lung, so there's less binding capacity left, and the driving gradient for oxygen diffusion is huge. But for carbon monoxide CO, which binds to hemoglobin much, much more tightly and actually more slowly, that binding term becomes far more important. It contributes about equally to the overall DL resistance along with the membrane term. This difference is actually critical for how we test lung function clinically, which we'll get to. And carbon dioxide CO2 is even more complex. Interestingly, despite being about 23 times more soluble in water than oxygen, which you'd think would make its DL much higher, its overall DL is only maybe 3 to 5 times greater than oxygen's. This is likely due to its more intricate interactions. It doesn't just dissolve. It reacts with water via carbonic anhydrase, binds to hemoglobin differently, involves other transporters within the red blood cell. It's complicated. So, yes, to your point, DL isn't just about crossing a physical barrier. It's very much about how gases interact with the blood itself once they get there. It's a holistic measure.
Right, right. Okay, this leads us perfectly into a crucial concept for understanding gas exchange, especially when things go wrong in disease. Is the problem getting the gas across the barrier, or is it getting enough blood there to pick it up? This brings us to the fascinating race against time inside your lungs, whether gas transport is diffusion limited or perfusion limited. Let's start with carbon monoxide, CO, because as you said, it's different, and it's kind of the classic example of one of these scenarios, right?
Exactly. CO is the classic diffusion-limited gas. So imagine you breathe air with a very low, safe level of CO, say 0.1%. What happens is that CO diffuses from the alveoli into your blood plasma. Then it quickly moves into the red blood cells, where hemoglobin binds it incredibly avidly, like it grabs onto it and doesn't let go easily. Because hemoglobin effectively traps almost all the incoming CO, the concentration of free CO floating around in the blood plasma remains extremely low. Your blood acts like a perfect sink for CO. It just gets sucked in and essentially disappears from the free-floating state as far as the diffusion gradient is concerned.
So the blood just keeps pulling CO in, almost like a vacuum cleaner or a black hole.
Exactly, that's a good way to put it. As blood flows down the length of the pulmonary capillary, the partial pressure of CO in the capillary blood, we call it PCCO, rises only very, very slightly. By the time the blood leaves the capillary, maybe 0.75 seconds later, PCCO is still far below the CO partial pressure back in the alveolus. This means CO never gets a chance to reach diffusion equilibrium between the alveolus and the blood within the time the blood is in the capillary. And here's the proof it's diffusion limited. If we could magically double the lungs' diffusing capacity for CO, the DLCO, the actual uptake of CO into the blood would also double. This shows that CO uptake is predominantly diffusion limited. Its transport is entirely limited by how fast it can diffuse across the barrier and get bound by hemoglobin. It fails to reach equilibrium.
Okay, that makes sense. It's bottlenecked by the diffusion step itself.
Yeah.
And what about blood flow? If you change how fast blood is moving through the capillaries for CO, does that speed things up?
Interestingly, no, not really for total uptake. If we were to have the blood flow, the blood would spend twice as long in the capillary. Now, during that longer time, the PCO would rise twice as steeply, sure. But because the total volume of blood flowing through per minute is halved, the total amount of CO taken up by the body per minute remains pretty much the same. Doubling blood flow also has very little effect on total uptake. For the same reason, the limitation isn't the amount of blood, it's the rate of diffusion. So, CO uptake is largely insensitive to changes in perfusion, reinforcing that diffusion is the bottleneck.
Got it. Now for the other side of the coin, let's talk about nitrous oxide, N2O, or laughing gas. How does it behave differently? You said it doesn't bind hemoglobin?
Right. Nitrous oxide is fundamentally different precisely because it doesn't bind significantly to hemoglobin or anything else in the blood. When you inhale N2O, it quickly enters the blood plasma and the red blood cell cytoplasm, but then it has nowhere else to really go. It just dissolves. So as blood flows down the capillary, the concentration of this free dissolved N2O and thus its partial pressure in the capillary blood, PCN2O rises very, very rapidly.
How fast are we talking? Does it equilibrate like right away?
Almost instantly, relatively speaking. Within about the first 10% of the capillary's length, the capillary N2O partial pressure has already matched the alveolar N2O partial pressure. Boom, equilibrium reached. So if the diffusing capacity for N2O somehow doubled, would the uptake increase? No. N2O would simply reach equilibrium twice as fast, maybe in the first 5% of the capillary length, but the total amount taken up by that blood would remain unchanged because it was already fully saturated or equilibrated so early on. This means N2O uptake is pretty much insensitive to changes in its diffusing capacity.
Okay, so if diffusion capacity doesn't limit N2O uptake, what does affect it then?
Blood flow, perfusion, that's the dominant factor here. If we have the blood flow rate, the total N2O uptake by the body also falls by about half, simply because less blood is flowing through the lungs per minute to pick it up. Conversely, if you double the blood flow, you double the N2O uptake. Therefore, N2O transport is predominantly perfusion limited. Its transport is limited by how much blood flows through the capillaries, not by how fast the gas can cross the membrane, because it does that almost instantly. Maybe think of it like this. Imagine workers, that's your diffusing capacity, DL, Trying to load boxes of gas onto railway cars, hemoglobin or blood volume, of a moving train, your blood flow or perfusion. For CO, the cars have huge capacity, hemoglobin binding, but there aren't enough workers. Or the workers are slow, low effective DL because of slow binding. The train leaves with cars still mostly empty. It's worker limited or diffusion limited. Adding more workers, increasing DL helps. Changing train speed doesn't help much. For N2O, the cars have very limited capacity, just dissolved gas, no binding, and the workers are super fast, high effective DL. The cars get filled up almost immediately. The train leaves fully loaded very early. It's train speed limited or perfusion limited. Adding more workers, increasing DL, won't help load more onto that train. You need a faster train, more blood flow to transport more boxes over time.
Okay, that train analogy really helps clarify it. So the core distinction boils down to whether the gas actually reaches partial pressure equilibrium between the alveolus and the blood by the time the blood leaves the capillary. If it does, it's perfusion limited. If it doesn't, it's diffusion limited. Got it. So how does all this apply to the gases that really matter to us every second? Oxygen and carbon dioxide. Are they diffusion limited or perfusion limited under normal, healthy circumstances?
Under normal, healthy conditions, at rest, both oxygen and carbon dioxide transport are considered perfusion limited. Let's look at oxygen uptake first. Blood enters the pulmonary capillaries relatively low in oxygen with a partial pressure, a PO2, of about 40 millimeters of mercury. The amazing thing is that the capillary PO2 reaches the alveolar PO2, which is around 100 millimeters Hg, very quickly. It equilibrates typically within about the first one-third of the way along the capillary's length.
Wait a minute. Oxygen binds to hemoglobin, just like carbon monoxide does, right? So why does oxygen equilibrate so quickly and act perfusion limited, while CO doesn't equilibrate and is diffusion limited? That seems like a bit of a contradiction.
Yeah, that's an excellent question, and it really highlights the nuances. It comes down to three crucial differences between O2 and the low-dose COEs for testing. One, remember how hemoglobin entering the pulmonary capillary is already about 75% saturated with oxygen from its trip around the body? This means its available binding capacity for new oxygen is much lower than the essentially empty hemoglobin is for CO2. The initial driving gradient, the partial pressure difference between the alveolus and the incoming blood, is much larger for oxygen, about 60 millimeter Hg, 100 minus 40, compared to the tiny gradient we set up for CO testing. This large gradient causes an immense initial diffusion rate for oxygen. 3. And the overall DL for oxygen, DLO2, is inherently higher than for CO, DLCO, partly because that theta times VC term, the reaction rate with hemoglobin, is more favorable for oxygen under physiological conditions. Because of these factors combined, oxygen rapidly approaches its equilibrium carrying capacity, and the capillary PO2 quickly matches the alveolar PO2. What this means in practice is that your lung has a tremendous DL reserve for oxygen uptake. Even if your actual membrane diffusing capacity, DM, or your DLO2 were somehow cut in half due to some impairment, oxygen would still likely reach a fusion equilibrium. It would just take a bit longer, maybe reaching equilibrium 2/3 of the way along the capillary instead of 1/3. This built-in reserve is incredibly critical for our survival and ability to adapt.
And where does that reserve really shine? When do we actually dip into that extra capacity?
During exercise, of course, that's the classic example. Your cardiac output, the amount of blood your heart pumps per minute, can increase maybe up to 5-fold during strenuous exercise. This drastically decreases the transit time, the contact time that each red blood cell has within the pulmonary capillaries. It's moving much faster. But thanks to that tremendous DL reserve we just talked about, even with vigorous exercise, your capillary PO2 still virtually equilibrates with the alveolar air by the end of the capillary in a healthy person. This allows your oxygen uptake to increase proportionally with cardiac output, which is absolutely vital for meeting the massively increased metabolic demands of exercise. Without that reserve, exercise would be severely limited.
Okay, but what if someone has lung disease? Can that reserve be overcome? Can oxygen become diffusion limited then?
Yes, unfortunately it can. In patients with certain pulmonary diseases, particularly those that cause thickening of the alveolar blood gas barrier like pulmonary fibrosis, the DLO2 can be reduced significantly. It can be reduced enough that oxygen fails to fully equilibrate by the end of the capillary, especially during the stress of exercise when transit time is short. In such cases, oxygen transport becomes diffusion limited. The same thing can happen at high altitude. The lower barometric pressure means lower ambient oxygen, which lowers your alveolar PO2. This reduces the driving gradient for diffusion. So the combination of exercise, short transit time, and high altitude, low driving gradient, can actually make oxygen transport diffusion limited even in otherwise healthy individuals.
So oxygen is normally perfusion limited, but can definitely become diffusion limited under stress, like exercise or in disease states or at altitude. What about carbon dioxide? How does it behave? Is it similar?
Carbon dioxide follows a similar pattern, generally speaking. Remember, mixed venous blood entering the pulmonary capillaries has a PCO2 of about 46 millimeter Hg, while the alveolar PCO2 is around 40 millimeter Hg. So carbon dioxide diffuses in the opposite direction from oxygen from the blood into the alveolus to be exhaled. CO2 equilibrates quickly, partly because its overall DL is actually about 3 to 5 times greater than that of oxygen, mainly due to its much higher solubility. However, there are a couple of factors that tend to slow down CO2 equilibration compared to what you might expect from its high DL. First, it has a smaller initial partial pressure gradient, only about 6 millimeter Hg difference, compared to oxygen's 60 millimeter Hg. Second, its dissociation curve with blood is steeper, meaning a small change in partial pressure corresponds to a larger change in content, which can slow down the equilibration of partial pressures. Despite these counteracting factors, most physiologists believe CO2 also equilibrates quickly under normal resting conditions, probably reaching equilibrium around one-third of the way along the capillary, just like oxygen. This makes it normally perfusion limited. But, very similar to oxygen in certain lung diseases or during really heavy exercise, CO2 transport can also become diffusion limited. The reserve is there, but it can be overwhelmed.
Okay, that makes sense. Given how important diffusing capacity is, especially for understanding limitations in disease, how do clinicians actually measure it in patients? I imagine it's not as simple as just, putting a gas mask on someone and hoping for the best.
Right, measuring DL is incredibly valuable clinically. It helps diagnose certain lung diseases, track their progression, and assess the severity of impairment. And surprisingly, as we hinted before, we use carbon monoxide to estimate it.
Ah, right. You use CO because its uptake is usually diffusion limited under test conditions.
Precisely. Because its uptake is diffusion limited at the low concentrations used, any changes in the lung's actual diffusing capacity, DL, have a nearly proportionate effect on the measured CO uptake. This makes the CO uptake an excellent indicator or proxy measure of the lung's overall diffusive function for gases. Plus, another advantage is that the driving pressure for CO, the partial pressure difference, falls reasonably linearly along the capillary under these test conditions, which makes the calculations required to estimate DL much simpler for clinical purposes compared to O2 or CO2. There are two main methods clinicians use. One is the steady state technique. This involves having the patient breathe a very low, safe concentration of CO mixed with air for several breaths until the amount in their alveoli stabilizes. Then you measure the rate of CO uptake by comparing the inspired and expired CO concentrations, and you also measure the average alveolar CO partial pressure. DL is then simply calculated as the CO uptake rate divided by that average alveolar driving pressure. More commonly used today, though, is the single breath technique. This is probably what most listeners would experience if they had the test. You exhale completely down to your residual volume. Then you take a single maximal inspiration of a special gas mixture containing a very dilute concentration of HCO, along with an inert, non-diffusing tracer gas like helium or methane. You hold your breath for exactly 10 seconds. The tracer gas, like helium, hardly diffuses across the lung barrier. So by measuring how much the helium was diluted during that single breath, we can figure out the initial alveolar volume and how much the CO was diluted just by mixing in the lung. Then we measure the CO concentration in the air exhaled after the 10-second breath hold. By comparing the initial calculated alveolar CO concentration to the final measured concentration, we can determine how much CO diffused into the blood during that 10 seconds, and from that, calculate the DLCO.
Okay, so these tests give you an average diffusing capacity for the entire lungs, the DLCO value. What sorts of factors, beyond just intrinsic lung disease itself, can actually affect that measurement? What might make it higher or lower?
Yeah, that's a really important point for interpretation. Many things can influence the calculated DLCO value, for example. Body size and sex. Generally, larger individuals and men tend to have higher DLCO values, largely because they have larger lungs and thus larger total alveolar surface area and capillary blood volume. Age. DLCO tends to peak around age 20 and then gradually decrease thereafter, maybe by about 2% per year on average. Lung volume. Taking the test at a higher lung volume generally increases DLCO because it stretches the alveoli and capillaries, increasing surface area and perhaps capillary volume. Exercise. Exercise increases DLCO significantly because it recruits previously closed pulmonary capillaries and distends open ones, increasing both the surface area for diffusion and the volume of capillary blood. Body position. Lying down, supine usually increases DLCO compared to standing up, likely due to gravity causing better perfusion and recruitment of capillaries in the upper parts of the lungs. And crucially, something we need to highlight: anemia. This is a really important potential confounder, a clinical gotcha. Remember how the overall DL has two components? The membrane diffusion, DM, and the reaction with the blood, theta times VC. Well, for carbon monoxide, that theta times VC component, which depends heavily on the amount of hemoglobin available in the capillary blood, makes a very significant contribution to the overall DLCO measurement. Therefore, a fall in the total hemoglobin content in the blood, as occurs in anemia, can significantly reduce the measured DLCO value, even if the physical diffusion pathways in the lung membrane itself are perfectly normal. So, a clinician seeing a low DLCO needs to consider anemia as a possible cause or contributor before jumping to conclusions about intrinsic lung disease. It's a classic example of how interconnected our physiological systems are.
Wow, that's a critical nuance. Thanks for pointing that out. So, following on from that, if a patient does have a genuinely reduced DL, maybe due to lung fibrosis or emphysema, does that automatically mean they'll be hypoxic? Does a low DL directly translate to low arterial oxygen levels?
Not necessarily, and this is where clinical understanding really comes into play, beyond just the numbers. While it's true that many lung diseases that reduce DL also cause hypoxemia, low arterial oxygen, the decrease in DL itself isn't always the sole or even the major cause of that hypoxemia. The same diseases that damage the lung tissue and lower DL, like emphysema or fibrosis, often also severely disrupt the matching of ventilation, airflow, and perfusion, blood flow, throughout the different regions of the lung. This is known as VQ mismatch. And VQ mismatch can be an extremely powerful cause of hypoxemia, sometimes contributing much more to the low blood oxygen than the reduction in DL itself does. Plus, remember that significant DL reserve for oxygen we talked about earlier? In healthy people, the DLO2 is so high that oxygen transport normally remains perfusion limited, even if DL drops quite a bit. Your overall DL would likely have to drop to about 1/3 of its normal value before oxygen transport starts to become diffusion limited at rest. So disentangling the exact contribution of reduced DL versus VQ mismatch to a patient's hypoxemia and complex lung diseases can actually be quite challenging. It's often a combination of factors.
Okay, that really puts the clinical measurement in perspective. It's a valuable piece of the puzzle, but not the whole story. So let's recap. We've taken a deep dive today into the really elegant physics and physiology of gas exchange. We started with Fick's law, understanding how it governs the movement of gases based on their properties like solubility and molecular weight, and the characteristics of the barrier, its area and thickness. We then distinguished between diffusion-limited transport, using carbon monoxide as the classic example, where the barrier crossing is the bottleneck, and perfusion-limited transport, using nitrous oxide, where blood flow is the limiting factor. We saw how these principles applied to the vital exchange of oxygen and carbon dioxide, normally perfusion limited thanks to a large reserve capacity, but potentially becoming diffusion limited under stress, like heavy exercise at high altitude or in certain lung diseases. And finally, we explored how diffusing capacity is actually measured in a clinical setting using the DLCO test, and discussed the crucial clinical implications and nuances of interpreting that measurement, especially considering factors like anemia and the often concurrent issue of VQ mismatch. It leaves me with a provocative thought, though. Considering the lungs' incredible DO reserve for oxygen, designed for our current atmosphere and activity levels, what might be the physiological limits or perhaps the adaptations required for humanity to truly thrive long-term in environments with significantly lower oxygen concentrations, maybe beyond what we currently experience even at the highest inhabited altitudes? It really makes you appreciate how fine-tuned our respiratory system is for Earth as we know it. Now, this material is complex, there's no doubt about it, but you've just absorbed a wealth of detailed information, hopefully broken down into manageable pieces. Remember, you are part of the Deep Dive family, and you are absolutely capable of mastering this material. Keep building on this knowledge, review it, think about it, and you'll be well informed and feel much more confident in your understanding of this core area of medical physiology.